Why don't you give it a start?
Thank you, Chris. We were going to keep that a secret, but I guess we'll just let everyone know ahead of time. This has nothing to do with our personalities. We are so excited to introduce this program to the department for what it is now, for what is the potential for a program like this in the future, and other programs like it. Next slide. Here you can see our disclosures. Next slide. So what we'll do today is we will review the enhanced stroke recovery as it exists today in the Mount Sinai system. We will look at the pilot trials that we're trying to perform here. We'll also take a look at the VNS Rehab Pivotal Trial that just received FDA approval. We'll take some time to review the ViviStim device as well as the implantation of it. And then the enhanced stroke program recovery in action and the possible future directions as this program takes off. Next slide.
This is a standard stroke recovery curve for patients who have had ischemic stroke. And we're looking at upper extremity arm function here. And so patients suffer the stroke and they get worse for a few days as they suffer the initial ischemia and then the swelling associated with the ischemia. Then they initiate rehabilitation and they have some improvement in function, and then they reach a plateau phase thought to occur around the 3 to 6 month period. And then depending on their activity and the treatment they're receiving, some of them continue to plateau, some receive treatment that aids them in continuing to improve, and some actually start to worsen after that in that chronic phase. Entire careers have been built around the recent discovery of treatments in this phase, specifically thrombectomy. And there is a lot of device development and drug development around treating patients in this window. There is not much that we're aware of in our space in this window here. We have heard a little bit about stem cell injections being done at Stanford. And we have also heard a little bit about other forms of stimulation that can be done here. And last week, we heard about a potential digital bypass that can help augment function in the chronic phase of stroke. But today, what we're going to focus on is vagal nerve stimulation to treat patients in the chronic phase of stroke to improve upper extremity function. And this is work that's been going on for quite a few years, although I was previously unaware of it. It was a little bit under the radar in the neurosurgery stroke space, at least. This pilot study was published in Stroke in 2018, and this used a very specific form of vagal nerve stimulation called paired vagal nerve stimulation. And in this specific strategy, a vagal nerve stimulator is implanted in a patient who has had an ischemic stroke, and that ischemic stroke occurred at least 6 months prior to this training and treatment paradigm. Then while the patient's performing the movement, the therapist presses a button and activates the stimulator. So each time the movement is being made, the stimulator is activated. It's not that the patient has the stimulator activated, performs a lot of rehab, and then has it turned off. This is paired with every single movement. The rehabilitation paradigm that this team developed includes 3 rehabilitation sessions per week for 6 weeks. And in each session, they do approximately 300 repetitive movements that are task specific. So in this trial that I just mentioned, the pilot study, first the treatment arm engaged in paired rehabilitation for 6 weeks. Then they engaged in home-based rehab, in which the VNS was turned on. They did their home rehab, and then it was turned off. And when it was turned on, it would give a pulse every 10 seconds. So in this pilot study, 22 participants were consented, 17 were randomized, and then it ended up that there were 8 in each group, given some exclusions and people who exited from the study. Patients who were in the VNS group underwent paired rehabilitation, which was in clinic, and then they went home. They got an assessment, then they went home, and they had a 30-day ramp-up period at home. Then they started engaging in at-home therapy with the VNS turned on. And so here you can see the change in the patient's Fugl-Meyer assessment, and I'll go into exactly what that is. And you can see that there was a notable improvement in patients who had the VNS turned on. And then this is the control group, patients who did not have VNS turned on. So you can see that rehabilitation is improving both groups, but is it improving the active VNS group more? There was no statistical difference in this pilot study at this level, but there was statistical significance at this later time point after both the in-clinic therapy and the at-home therapy. Then the groups crossed over. And so the group that did not have the VNS turned on, but they did have it implanted, then crossed over and then underwent in-clinic therapy. And that group then did show an improvement at that point. I'm just going to talk a little bit about what the Fugl-Meyer assessment is. This is a much more complex scale than what we're used to performing for the NIH stroke scale. This is a test in which each item is scored on a 0 to 2 scale. 0 is the person could not perform it. 1 is they could perform it partially, and 2, they could perform it fully. And then there are 5 domains. There's motor, sensory, balance, joint range of motion, and joint pain. And this study and what we're going to talk about today is motor function, specifically in the upper extremity. This can be divided into upper extremity and lower extremity. So that just gives you a sense of what this outcome measure is that these studies are looking at. That led to a pivotal study being performed that was published in Lancet in April of 2021. And that inspired this talk here and a lot of the work in this field that people are now implementing programs, implanting VNS and treating patients who have chronic stroke. And so in this study, there are 195 patients who were assessed for eligibility, 108 underwent implantation and were randomized. And so there were then 53 assigned to the active VNS group and 55 assigned to the control group with the same paradigm as the paradigm I previously described. And the results of this study show that the control group had a Fugl-Meyer assessment upper extremity improvement of 2.5, and then the VNS group had an improvement of over 5 on average. And this was after they had their in-clinic therapy. And then they started doing their at-home therapy. And it appeared that the patients who had the VNS implanted did continue to have a slight improvement, while the control group also had a slight improvement. And there remained a statistically significant difference between the two groups with far more improvement in the VNS group. The group also looked at what percentage of patients were responders. And they defined a responder as somebody who had a clinically meaningful response of 6 points or greater on the upper extremity Fugl-Meyer assessment. And that was based on prior literature in which patients who had a 5.25 point change were considered to have had an excellent improvement with greater than 50% improvement in arm function. And so this prior literature unrelated to this group gave them this definition of 5.25. So they used 6, and 50% of patients in the VNS group had a 6-point change or more.
Thank you, Chris. So a quick review of the past, the present, the future, and the enhanced stroke recovery options as we go forward. Go ahead and click. So in the past, even going further back, about 2,000 years ago, people have been trying to afferently stimulate the nervous system to affect the brain. One of the mentors of Galen of Pergamon, Pelops, used to give painful stimuli with ligatures to try to stop seizures. And that would be just kind of tying people's fingers and using that painful stimuli to trigger the system. Beyond the scope of this talk would be the research that is out there, non-invasive modes, TMS, transcranial direct current stimulation. Some exciting work has been happening in the DBS domain. And here we want to mention Andre Machado's trial from Cleveland Clinic. It's more than a decade worth of work where they're stimulating in the cerebellum and are able to get right now in open label, just beginning of that research, Fugl-Meyer improvements of up to 10 points. But we're still at least 5, maybe 10 years away from that truly coming to fruition. So in the present right now, the best way to enhance these patients and their outcomes would be vagal nerve stimulation. In the near future, as the DBS really takes off and we have these other incredible options, as we discussed before, the stent road, movement trials, stem cell injections. Next one. In the future, we're hoping that each specific patient will have therapy that is designed for them. And this will include everyone from neurosurgery to neurology to rehabilitation doctors. And we will get to that. It's just a significant process and where I think the strength of this program does rely. So this right here is the FDA notice of approval for Vivastim that just came out earlier this year, the microtransponder system. And from this point on, insurance companies should be approving this device. And that really has triggered the push at Mount Sinai to proceed with this program. Next slide. So a little bit of a background, and I apologize if this is too lowbrow for some of us who do vagal nerve implantation, but it will be helpful for the residents and others listening in who are not neurosurgeons. So the Vivastim system is similar to what we classically call vagal nerve stimulation. It's a device that is a two-part incision implanted in the neck, as well as usually subclavicular or preaxillary for the incision. It has usually two contacts and another little stay wrap that gets wrapped around the vagal nerve itself and then tunneled over to the lower incision. Next slide. So here you guys can see a fairly standard approach to this. For all of us who use spine a little bit more, this is akin to an ACDF incision for C5, C6. For those of us who do more carotid approaches, this is a smaller kind of a mini carotid endarterectomy approach. And the pocket is done either in the axilla, close to the axilla, or more of a classic DBS battery approach, 2 finger breadths below the clavicle. After that, the dissection happens down to the carotid sheath itself. Next slide. And here you can see the outline of the opening. You can see the carotid medially, you can see the jugular vein laterally, and the nerve usually lies in between them and deep. Sometimes there's an anatomic variation where it would be more superficial. And at this point, this is an incredible exercise in manual dexterity and patience, where you are wrapping the small coils around the vagus nerve itself. There's a couple of tricks that help. Eddie Chang at UCSF used to put a small cut rubber glove underneath it to isolate the nerve. Some folks will use vessel loops to gently lift it up to make that part of the process easier. There's some great training that residents can do before these cases on a model that simplifies this a little bit, but really gets them into the right approach as to how to do this using the correct instruments in surgery. After the vagal nerve stimulator itself is implanted, you secure it with some tension relief sutures to the SCM fascia, and then you tunnel it to the pocket and connect it to the IPG. The most common complications from this case are hoarseness of the voice. We are dealing with the vagus nerve, some discomfort in the area, and a very low chance of larger possible complications, including vascular injury. Next slide. So why do we think this works? And as Chris stressed, this is decades and decades of work. And actually for this one, Chris, let's just go to the next slide right away. It shows it as well. But overall, again, we're increasing global neuroplasticity, and we are accentuating the extensive synaptic reorganization that happens with rehabilitation. So as you can see here on the left, task-specific practice, as Chris described, together with relevance from the behavioral perspective. The patients need to understand and need to know that this is getting them better. The lower left-hand side shows you just how many theories there are as to how VNS works. Some of the most recent literature is the simulation of the locus coeruleus and the noradrenergic spread through the brain that happens after that contributes to the synaptic reorganization. You guys can see in the middle here, the sensory motor neuron activity together with neuromodulation gives you this long-term neuroplasticity. And you can see the graph here from the 2016 study that shows that the VNS plus rehab does better than VNS itself. On the right-hand side, you can see mice and rat models that show that there's going to be greater nerve recruitment on both sides of the hemispheres with VNS paired rehabilitation versus just intense rehabilitation without the neuromodulation. Next slide.
So this is the paradigm that was used in the study. And the most important thing to emphasize here, that was even emphasized in Jeremy's talk, is that this is a multidisciplinary program in which you need close collaboration between neurologists, neurosurgeons, rehabilitation doctors, patients, of course, and industry. And so in this protocol, the patient undergoes the surgery, has the device placed, then undergoes baseline testing, then has their in-clinic rehabilitation 42 days where they're going 3 times a week and they're having in-person paired VNS where the therapist is pressing the button. So you've got to have a therapy team who's highly engaged and performing this rehabilitation. We've been working with the Abilities Research Center with the rehab department here at Mount Sinai to develop this paradigm, and that's Dave Petrino's group. Then they undergo their post-in-clinic rehab testing. Then they continue performing their at-home rehab as they did in the study. We're also adding, because of the cost, the upfront cost, and the challenge of making sure patients will comply with this long and arduous paradigm, we're mandating a prehabilitation 1-month period where they meet the rehabilitation team and they go to rehab in the same way they will in this in-clinic rehab for 4 weeks. During this period of time, they're also enrolled in the Precision Recovery Program, and they're entering their data at home, and they're having their examination recorded on a weekly basis. Here's that app that we've developed a little bit since the last time you heard about it. So this has kind of some basic features. We're able to link up some physiologic monitors, and we're able to have the patient fill out the survey, just a few questions each day. And then the clinician is able to monitor how that patient's doing. So each patient will be logging high resolution physiologic survey and neurologic function data. Here's that automated app we've been using for monitoring the patient's movements, and the patients will be recording themselves. So we have a highly resolved method of tracking the patient's movement over time that's going to be more, we think, better at detecting improvement than even the Fuglemeyer, which, as you heard, was either a 0, 1, or 2 for each muscle group. The specific eligibility criteria for patients who could potentially have this done, these are for patients, at least the FDA indication is for patients who have ischemic stroke. That could change in the future if another trial focusing on ICH or other diseases shows benefit. The animal studies suggest that there probably will be benefit for ICH that's similar to the benefit for ischemic stroke. So that's going to be an exciting area of research. If a patient has to have some upper extremity weakness, of course, because that's the target improvement. And so a patient has to have an NIH stroke scale of 1 to 3. If they have a 0, they're not bad enough. And if they have a 4, they're unlikely to benefit because they're not able to perform the tasks necessary to engage in the task-based paired rehab. Patients also need to have some sensation, and that was described in the study, and that's so that they can also maximize their participation in task-based rehab. And of course, they can't have a prior vagotomy. We have already developed a prospective registry. So just to emphasize, what we're talking about today is clinical practice, but we want to monitor outcomes in this program. And so we will have a parallel quality assurance database, and every patient that provides their consent will also have their data prospectively recorded in a research registry. We estimate that there will be a large number of patients in our system eligible for this annually. We have 1,900 ischemic stroke patients in the Mount Sinai Health System annually. 66% of those patients have arm weakness by the data. And after 6 months, about 10% of those completely recover, and so therefore would be ineligible. So there are about 60% of patients, just kind of looking at the broad group, and that leads to about 1,140 broadly eligible patients. Of course, we would have to look in more detail about whether or not those patients can really undergo this procedure and they have the social support to engage and comply with the rehabilitation program. Ted? Sorry, I took your last slide there.
No, it's all right. We made it work until the end. So the goals and the future directions, and to us, this is the most exciting part. We can really improve the stroke recovery of patients for whom really not a lot has been available once, as Chris pointed out, they reached a plateau. We are set up here as a center to perform this prospective high quality research. And this is leveraging the work that Chris and Dave Petrino have done in the past, and really building on the fact that it's a cohesive team that works at Mount Sinai together. We most certainly can have this grow into an enhanced stroke recovery program in the future. That includes everything that we mentioned so far in this talk. I think that all of us do think that the creation of future cyborgs is easier than regrowing the nerves, but we will be approaching this in combination. So we will be bypassing neuronal circuits that no longer work with creation of brain-machine interfaces, but at the same time, we will be stimulating whatever recovery can still happen in the circuits that are intact or can take over. And of course, intracerebral hemorrhage is a big question mark at this point, but all that we've seen so far would point us to the idea that those patients will benefit. Another stressor to place here is that the way that the trials are designed for them to take away the placebo effect and natural recovery, they had to wait for the chronic phase. Whereas we really go into the real world, both Chris and I and some of the other people in the field do think these patients may benefit from implantation earlier, from rehab earlier, from stimulation earlier, and that can potentially even improve their down the road outcomes. And I want to make sure that we both also thank Roshini Kalagara and Susmita Generetti, who helped with the slides and the preparation of this. They're excellent medical students that work with Chris on these projects. So with this, we want to thank you guys, and we want to leave some time for questions. This is an exciting opportunity for the center, and we think that the amount of patients coming through potentially will be a lot. So we will need the help.
I see Shram Majidi has a question here.
Yeah, thank you very much. Really exciting program. Congratulations, both of you. This will really put our program forefront of stroke recovery research. Two questions. One, as we know, the neural plasticity is time dependent. One of the critics of this Mass General pilot study and subsequent clinical trial was the included patient 4 months after stroke up to 6 years. So what would be the timeline that we will be using in this program?
According to the studies, they did not have the power to evaluate if there was a difference in improvement based on the chronicity of the stroke. But they comment that they think that there is benefit even for patients with severe chronic stroke. So, up to, I think the latest patient in the study was up to 9 years, as you mentioned. So I think that's one reason to very carefully monitor outcomes to see if there's a difference in the amount of time until implantation and treatment. But according to the study, chronic stroke is chronic stroke. So that's any patient after 4 months in the pilot and then 6 months in the trial.
Some people argue that there might be even role for VNS in acute stroke, taking into account anti-inflammatory, anti-glutamate potentials of VNS, but that's a different topic.
Yeah, as we were discussing offline, there are cutaneous methods of stimulation, but those really haven't panned out in animal models to be as effective as the implanted paired VNS. And so it might be that you just can't stick to the paradigm enough. You can't get those 300 repetitions if it's not implanted, or it's not getting to the right part of the nerve and getting as robust a stimulation as an implanted stimulated.
Yeah.
And then a quick follow-up as well here. So yeah, from the perspective of doing acute, urgent VNS, the center has experience with that. We run into that when somebody's in status and nothing else is working. So we are able to do this on a more acute basis. And I think that eventually the program will head in that direction, as you said, to stress the fact that it's not just neuroplasticity and neuromodulation, but also that it's potentially inhibition of the inflammation that's happening. That would be outside of what's recommended right now. But to me, Sinai is the place to potentially try something like that and to keep that going as a project.
That's great. This last question, Ted, any potential role for percutaneous CNS in future?
Well, I think, who was it? Chris got stimulated like this by Dave Petrino at some point when he was going through his bout of clinical depression after call. Most certainly, I think that the whole field is moving from being able to get good enough intracranially at the source, and then slowly reverse engineering approaches that will become more and more minimally invasive. We're trying that in epilepsy, we're trying that in neuromodulation, it's been tried in depression, and for sure, eventually we're thinking that this stimulation can happen targeted and without the invasive procedure. But I think we have to go through the building blocks of getting there.
Thank you.
Dr. Hadi Panaz.
Yeah, my connection may be off here. Can you guys hear me okay?
Yeah, we can hear you.
Okay. One of the things I was thinking about, Chris and Ted, I don't know if you guys were part of the grand rounds we had with Mike Shragru with Connectomics. And, Chris, you and I have been communicating about this, but it may be nice to somehow incorporate some resting state MRI data into this, and then look at, some of the recovery data in terms of connectomics. And the other thing too is, transcranial magnetic stimulation is another area kind of rapidly growing in parallel here, with some of these recovery efforts in patients with brain tumors, with strokes and other issues.
Yeah, absolutely agree. Both TMS, direct transcranial as well. I think all these things will grow together. We're starting out at different spots. We as neurosurgeons are focusing more on the invasive procedures that we know well and we're taught. Whereas a lot of other neurologists and rehab physicians will be pushing that TMS. Connectomics is a great idea. And I think that downstream goal is to have this be as patient specific as possible. And maybe the connectomics analysis will rule out some cases where we see that they will not benefit long-term and actually will help us even further delineate the stimulation that we need to provide. All of that is still to be learned and to be discovered.
Are we nearing the end? If so, I wanted to ask a question that gets back to how we started with Chair's Corner this morning. Noah, are you still on the line? Looks like Noah had to step out. So Brandon, along the lines that we discussed of, how to evaluate programs, what do you think would make me the happiest about this fantastic presentation that we just heard? What do you think that makes it stand out?
I think one thing that stood out to me is that there's a lot of collaboration between different people in our department within the different sectors of functional neurosurgery and vascular neurosurgery, and design and innovation, and working with ways to create new therapies, and bringing a lot of bright people together and having them in close proximity. You can really spin out a lot of fantastic projects like this.
You hit it right. You hit the nail right on the head. I mean, that's just so great. You've got a vascular guy talking to a functional guy. They don't even speak the same language. They don't even understand each other half the time. And yet, got a little bit of a seniority ish thing, but they're both collaborating together. So I just want to congratulate you. I'm sorry I had to step away during that part. I would love to see the other part of the slides. I've seen a little bit, but I want to see more. It's great. It's great. How can we amplify? My only real question is, how can we amplify this? What sort of resources are needed? And how can you amplify the effort beyond what it is now?
Yeah, I think at this point, the next step will be, we've had some offline discussions with the neurologists, really taking this presentation to the neurology grand rounds. I know some of the neurologists actually on this conversation right now, and getting the word out. A few patients will come back year after year after year, even 9 years out from their stroke, who can still now benefit from this. As we said, the trial goes out to 10 years. They can get benefit, but a few folks have given up. And it's really working through the system and finding people who are 6, 7 years past their stroke who think they cannot get better, and we want to get them to change their mind. And the other really important aspect here, I think this is Mark Harney from Canada, who stated, the financials are always important. It's always important for us to be able to sustain this program from the perspective of administration in the hospital. He phrases it as, breathing is not the goal of life, but breathing is pretty important to living. And we're happy to report that the initial financial analysis do seem favorable from the perspective of what insurances will reimburse for this. And while the margin may not be great, the volume of the cases will most certainly amplify that. So I think that we are in good position. And again, we welcome anyone and everyone who's willing and able to collaborate on this, because this will be a big project.
How do you think this relates to intention? That late curve with the chronic rehab phase, plateaued or improving or decreasing. I've usually said 18 months as my limit for when I'm expecting continued improvement on someone who suffered a deficit, whether it's surgical or stroke. But we find that there's some highly motivated people who force themselves to get better even after they've reached what should normally be the plateau. I wonder what that mechanism is and how that relates to stimulation that is, it's another type of stimulation, isn't it? Intention, motivation that are self-generated is another type of stimulation. I wonder how that relates to VNS and other types of activation.
Yeah, to me, this is the neuromodulation concept of resilience, and there's some great research in that, and Helen Mayberg is at our center. Not necessarily a complete, defense from stress. Resilience is not. Resilience is actually undergoing the stress, undergoing the trauma, but being able to long-term to continue to push for it. We have some incredible research where a cingulate stimulation, a little bit more mid-cingulate and posterior, actually creates this concept of increased resilience, where patients are able to undergo awake brain surgery easier, better if those areas are stimulated.
So what do you think the mechanism is, Chris, of that motivation versus stimulation, if there is any tie between the two?
The activation of the motion, engages multiple areas in the brain, and that system improvement is far more robust than direct cortical stimulation, and that recruitment of the system and building the network is critical. Without able to be more specific, I mean that to me is intuitive, and the data has shown that it's a circuit rather than a direct stimulation of the motor cortex.
Uh-huh.
I think also that just psychologically, these patients, they basically have no hope when they get to this plateau phase. And I have hundreds, maybe, at this point, thousands of patients who are in that phase, and they really don't have many options because insurance has run out and is no longer giving them rehab. So if they did get rehab, as you saw from the control group, they would still make some improvement, but they're unable to get that dedicated rehab. And so this is an opportunity to re-engage patients in the rehabilitation system in a way that benefits them, whether they're getting stimulation or not, and kind of rallies forces behind them in this a new hope of another phase of their recovery. So I'm excited about this because of that opportunity, as well as introducing a new treatment that's going to make it even better. The rehab department has some funding to fund these patients in this phase of recovery, even if insurance does not cover their rehabilitation three time per week session. So we can guarantee patients that they're going to get that intense recovery after having the implantation.
The other question I had was about things that do not have such a discrete event. My dad just turned 100 and he's lost a little bit of function, but he would like to have more function. He'd like to have some function come back. He never had an acute massive event that you would justify putting one of these in, but there are probably focal, there is loss and there's lateralization. What about what about the population that's just getting older and is losing function? How is it possible this could help?
Yeah, I think so. And I think this is where the non-invasive approaches probably are going to be tried first in patients with no severe significant stroke deficit. This is where TMS, transcranial, or potentially transcutaneous vagal nerve stimulation probably will be the way that the community goes first.
All right. Well, let's schedule the follow-up. When is the follow-up talk?
We're getting approval for the device, we hope, in early January. And so shortly after, we'll be able to give you an update.
All right. So 9 to 12 months from now, maybe?
Yeah.
Okay. Great. Thank you. It's very exciting.
All right. Thank you. Thanks, everybody.